All right, welcome to Lipstick and Check. Is it lipstick check? No. Welcome to Lipstick and Logic.
He's the lipstick, I'm the logic.
I'm not lipstick. I am not lipstick.
It's only on his neck.
I don't have any lipstick on my neck, do I?
I don't know. It's time for a lipstick check.
If I had lipstick on my neck, you'd be worried.
Well, that's what we're checking. This week, you were on
Yeah, I got
Daily
mentioned
Mail?
in the Daily Mail, which is a UK publication.
Okay.
So I was at we were both in a conference in Monaco last week or last month, and when we were in that Monaco conference, I did a segment with the PR team. The local news media wanted me to talk with me, and you know what they all asked me about? GLPs, GLP-1s. Like the Ozempics and the Mounjaro and the Wegovy, those type of medicines that are weight loss medications.
I mean, there's a lot of people that are on them right now. How many people are on them right now?
20% of the U.S. 19% of the U.S. population is now on or has tried one of those GLPs.
19%.
I know, it's huge. But you know what? Because 70% of people in the U.S. are overweight or obese. 70%. In Europe, it's 60%. Middle East, it's 30 to 50%. I mean, this is a worldwide phenomenon. So everywhere I go now in the world, people are asking about it. And I've written, you and I wrote a paper on it, but I've written quite a few things on it. I've been lecturing on it quite a bit. I did a keynote speech on it. So I'm knee deep. I'm super deep into the literature on this.
Right.
And
so what did you cover? What were some of the things that they were really interested in understanding?
Well, a lot of people, where we come in as aesthetic physicians is like, when do we treat them? Because when someone loses 100 pounds, I mean, they're losing a lot of their weight. When are they, should we start treating them aesthetically? And do they start to look older than their age? Mm-hmm. And are there other, where are they losing the fat from? Is it their face? Is it their body? Are they having accelerated aging? So there's a lot that we don't know yet.
Right.
What we do know is that we're seeing patients come in now. And if 20% of the population is getting this drug, we're going to see a lot more people are going to come in. They're going to start to want aesthetic treatments.
Now, these drugs aren't new. They've been approved since
2005. It was first approved.
Okay, but why are we seeing a boom?
Because they've gotten better.
Okay.
The results are better. And when semaglutide, 2017, I believe it was approved. When that got approved, it was a big difference. It was once a week.
Okay.
And
injection,
and people are losing 15% of their body weight. And it's incredible. And how the drug works, and we should talk about that, is it inhibits the glucagon, it inhibits a hormone release, a neuropeptide release, that then allows for blood glucose levels to go down, and it increases insulin, so it takes blood glucose, it takes blood sugar, and drives it into the cells where it should be. So blood glucose levels go down. Now, what people don't realize is that when you have a lot of sugar is poison.
Sugar is poison. I mean, honestly, like even with our baby Mateo, like I try to minimize any exposure. I mean, he's exposed to lactose because of his milk.
Well, we're talking about refined sugars here, not like
added sugars, are
sucrose,
just so, like, I'm trying my hardest because it's just as bad if people think that, like, other things are bad, like caffeine is bad for them or wine are bad. Sugars are bad for you.
Sure, and that's why I think it's so interesting because we have an epidemic in the U.S., right? We have an epidemic of diabetes, and diabetes type 2 is a nutritional disease. But when 70% of the U.S. population is overweight or obese, and 20% of children, adolescents, so now it's FDA approved for treating adolescents that are overweight over the age of 12.
Now,
think about that. Why are kids overweight?
Well, we definitely have some ingredients like high fructose corn syrup in our foods that are not even allowed or banned in other countries, right? So, very quickly though, for the person listening in, 2017, you mentioned how the semaglutide became approved, but then there was an approval finally it wasn't just for diabetes anymore, it was for weight loss, and
it was for weight loss, right? As long as you had another factor.
And that was like 2019 or 2021.
I think it was 2021.
Right. And so I think from that place, now we took something that was just for diabetics, and people that wanted to lose weight finally got the permission that they could also utilize this if they were, that 5-10 pounds you just can't shake off.
Okay, but you're not supposed to do that, right? Right now, it's only for people who are BMIs or very overweight or obese. It's not to be used cosmetically.
So obese being defined, just so that we're all clear, of a BMI of 30 or greater. Being overweight is a BMI between 25 and 30.
Right.
And a BMI of less than 25 is generally considered normal BMI.
Okay, so that's an important point because when I was talking to all these reporters, a whole room
Right.
of reporters, they weren't overweight, so they're all thinking to themselves, should I take this medication? I want to lose 5 or 10 pounds. Should I take it? But that's not the only reason people are taking it, because now cardiologists are giving it because it's heart protective. So in some of these large trials, like the VA trial, there were 200,000 people that were on it. There's a reduction in cardiovascular events, so less heart attacks, less stroke, 20% reduction. I mean, that's enormous numbers.
And just so that people can understand, like if you can almost understand why sugar is so bad, right? It puts you in like a hyperinflammatory state.
Right.
And ultimately, what does that mean to you? Inflammation essentially leads to age, and age leads to death, right? So like something that's aging, ultimately the end point of that age is that it deceases, it dies. So like in this case, inflammation causes many of the things that we see, not just heart disease, potentially memory loss,
dementia,
right? Potentially the way that we age.
Yeah,
There are
bones,
sort of multiple
joints.
studies that show, right? So inflammation is not a good thing, right? And so now if you can at least bring down or eliminate that cause, then you would think that all of these other organs would be functioning better.
So to your point, vascular dementia is reduced in some of these clinical trials, 56%. Reduction in Alzheimer's. Think about that for a second. If you could reduce dementia, vascular dementia, if you could reduce Alzheimer's disease, depression went down, suicidal ideations went down. And here's another incredible benefit of these GLPs, which no one ever imagined, is reduction in alcohol abuse and drug abuse. So it works on the reward centers in the brain. So unlike most weight loss regimens where you have to starve yourself or you have to discipline yourself, you're still hungry. With GLPs, the Ozempics and the Mounjaros and the Wegovy's, you're just not hungry. And you don't desire food. And if you're an alcoholic, you don't desire alcohol. And if you're a drug addict, you don't desire drugs. And if you're a shopaholic, like some people I know.
I still want to continue my shopping addiction.
So-
I'm totally fine with it.
Yeah, and you talk to people who are taking this, like, well, do you miss having a drink of wine? No, I don't miss it. You don't miss it? And that's what always fascinates me because, there's no greater pleasure in life than eating. Well, I can think of a couple that are pretty close. But eating is one of the greatest pleasures. And when you take that away from someone, would that bother them? And the answer
Or
to that
what do they
question-
spend their time doing? Some people just eat socially,
They're not bothered by
because that's
it.
what you do. You go out to dinner with a friend, or
But on top of it, they feel good about themselves. And now, this is the thing. I've talked to a bunch of people on this medication now. What I don't think most people understand is that if you have obesity, true obesity, there's something called food noise. In their mind is food. They cannot stop thinking about it. If you don't have this problem, if you're not having trouble with obesity or overeating, you don't hear that food noise. But it takes.
I have
them
other
over.
kinds of noise, like the Chanel pink purse that I
Yeah.
need to get. But okay, yes.
It overtakes their mind, and they become obsessed almost with eating food all the time. You take this away with this drug, they don't have that anymore. So what does it do? They feel in control of their emotions. They feel in control of their agency. To me, that is one of the reasons why their depression goes down, because someone who can master their appetite or emotions, I think, feels better about themselves. And I think that is one of the ways in which this drug is working. I think it also works on the dopamine, serotonin reward centers within the brain. But they feel better about themselves, less suicide. I mean, it's really amazing.
Okay,
what it
so
does.
let's bump up the jewels. These patients that present to us on these drugs, are you finding them that they're looking more attractive?
Well, so it's a good question. I know you and I have written about this. I think that initially they lose the weight. Everyone's like, oh my gosh, you look great. And they love it because everyone's like, look how wonderful you look. And they start to love that feedback. They look great. But something happens along the way where they start to lose a lot of weight and they start to look aged or hollowed out. And something is going on where they don't look good anymore. Now, where does that happen? It's hard to say. And I know that you have some theories on this as well.
Right, I think it comes down to, you touch on something that we talked about the last time, right? Which is like attraction, what makes people attractive. And a part of it is the feedback that they get from others. And so when you're getting all this constant feedback that you look good, wow, what are you doing? You're getting attention. That translates into feeling more confident about yourself. And that takes you so far, right? And then there's obviously something that has to be intrinsic that is sustainable and keeps you going when you feel attractive and confident. But with these patients, I agree that there's an element of what did you start off, what was your weight that you started off with first? What was your initial BMI? Somebody that's like a BMI of 25 and is pretty much normal, bordering being overweight, and loses perhaps 10 pounds, that's now they're at a BMI of maybe 21 and they look good and that might be it, right? But if somebody started off with a BMI of 30 and they lost 10 pounds, it may not make the dent that makes the difference, right? If they lost now 20 pounds, now they see a little bit, but are they feeling attractive enough? So I think it really comes down to how, and I think we're seeing this in our practice, how much should you start off weighing? Then how much weight did you lose and over what time frame? Because when you lose it quickly, I feel like we start to see some of these changes.
Most people in the studies lose it within the first 36 weeks. So
6
the
months.
massive weight loss happens in the beginning, and
Okay.
then it slows down after that in most of the clinical trials, which is really interesting. But you and I have talked about this in the past, but postmenopausal women too, because we believe this has an effect on the estrogen. Do you want to comment on that?
Right. So yes, I do want to comment about that but I want to then just really, summarize for, what we just talked about. When you lose that weight and you lose a certain amount of that weight, initially you're getting a lot of feedback, a lot of compliments, and that makes you feel attractive. It makes you feel more confident. And I don't think patients at that point are necessarily coming in to see us.
Well, first of all, these aren't typical aesthetic patients.
Right, because they were generally overweight, and the last thing
taking care of their skin. Yeah.
Right, the last thing they were doing is adding filler, doing something to their face. But now, you've maybe somewhere along the way, and I do believe that there is a window where you look really good when you're on this because of that inflammation that you've brought down. Like you can almost see like an inflamed face. Like we see it sometimes in our patients that drink a lot.
And smoke.
Smoke. Like they have a look to their face.
Yeah.
They come in, it's like they're puffier. They just look a little bit more inflamed, right? And so that sugar does that. It's like a
Maillard effect, it's called.
Huh?
It's called the Maillard effect.
Yes.
Right.
So it's like a sugar hangover,
Yeah.
okay? So not an alcohol hangover. You're hungover from the sugar you ate the night before, and you have a look to you. And I think that when you're on these meds, there is a window of time where that looks really good when you take that away.
Right.
But then there's a place, and that tipping effect, I think, is different for everyone depending on age and hormonal status, where now you start to tip into looking unhealthy. And I think it's more than just the volumetric change, the volume loss in your face change that makes you look unhealthy, which I think we've discussed how it preferentially is lost in the temples and the fat around the eye, right? But there's a place where you look unhealthy because the quality of your skin doesn't look as good as it used to look. You don't have that glow. You look a little ill. And perhaps it's not like the regular person's going up to you and saying, "Are you ill? Are you okay? Is everything okay?" But perhaps you're no longer getting the compliments that you used to get, like you did when you were initially losing the weight.
And I think the key you just kind of alluded to, it's not that it's a grape that turns into a raisin. It's not just like your face deflates and all of a sudden you have wrinkles and you look older. There's something else going on at the level of the skin, and it's biochemical. And you're saying, and maybe it's hormonal also. You take down the inflammation, to your point, initially, which is good, but you also lose fat. And fat is an endocrine organ, and especially in women that are postmenopausal, they lose that ability to create estrogen because the fat in the skin takes over of producing hormones when the ovaries stop producing after menopause.
Right. So if we're going to keep it real, if we're going to go into our keeping it real, then these drugs are great. As with anything, it's the answer somewhere in the middle. It's probably just recognizing that there is a tipping point for everyone, and it depends. It varies. A 20-year-old, it has a very different tipping point than a 50-year-old, and what weight they started at and how much they lost also influences this. But I think it becomes less forgiving. That tipping point is less forgiving when you are perimenopausal or menopausal, and we have to remember that the fat, which in dermatology we learn is the hypodermis. This is part of your skin. There's 3 layers of skin: epidermis, dermis, and hypodermis. We don't talk about the hypodermis, but that's your fat. That's the superficial fat plane that is essentially your second ovary. Okay, it is functioning to create estradiol and estrone for you, which are forms of estrogen. And if your ovaries, which start to kind of get a little sleepy in their 40s, are now relying on your skin, your fat cells specifically, your adipocytes, to do the heavy lifting for you and create that estradiol and estrone. And now you've essentially shrunk that fat and deprived it of creating the estradiol and estrone. Then what does that do? And it has an effect on the skin. And there was a paper that you brought to my attention, which is like, do overweight patients have less wrinkles? Do they look younger?
They do.
And they do, right? So and we know that those that have less wrinkles look younger. There's studies that actually show that wrinkles can contribute to perception of age of greater than 10 years.
Yeah.
So just throwing wrinkles on a face can make it look 10 years older.
So heavy people look younger.
So there's a place, not obese, but overweight. So there's a window there, right? And so now you've depleted this individual who's relying on that fat, and they didn't know they were relying on that fat, to eliminate their hormone function. And because what you said is so key, they lose it so quickly. Within 6 months, they're losing most of that weight. It's like there's not enough catch-up, perhaps, from the ovaries to make up the rest. And if you're in menopause, there's definitely no catch-up because that ovary is no longer.
And you and I also wrote a paper
senescent.
where we suggested that perhaps the GLPs have a direct effect on the skin, something called adipose-derived stem cells. And I think it's a little bit more than we should go into right here. But maybe it has a direct effect on some of these progenitor cells, some of these cells that help the skin to regenerate.
The stem cells of the skin,
cells.
Which are there. And they're there and available to us independent of age, right? And so what are the effects that we see when we're essentially in chemically induced menopause, right? What are the effects that we see in menopause? When you see a shift in a decrease in estrogen, what happens to the skin? I wrote a paper on this in like 2016, estrogen deficient skin. And essentially the skin is drier.
Yep.
It loses its water binding capacity at the second layer of the skin, the dermis. So it doesn't look as dewy. It doesn't look as radiant, right? It looks more wrinkled and it looks more dry.
So collagen and elastin are disorganized, and they also you have a thinner layer.
And then you're not creating, think of estrogen as a fertilizer.
Yeah.
You're no longer creating the collagen and elastin that are responsible, collagen for making the skin thick and elastin for making that skin recoil back onto the underlying muscle. And so now you have thin skin that's not recoiling back. And so all of a sudden, I get a lot of women generally, when they're starting to shift from perimenopause to menopause, saying, oh my God, I felt like my skin aged overnight. But now I'm also seeing patients on these GLPs notice that difference, but in a very short amount of time, because it's like a tipping point when they don't have enough fat anymore to make up the difference for their ovary.
Right, and then usually I'm seeing it around the eyes. That's where first place I'm seeing these people lose their fat. I'm seeing in the temple areas and around the eyes. They look hollowed out to me. And oftentimes they're coming to me because their neck is hanging. And they're like, oh my gosh, I have this neck hanging. Can you treat my neck? But if you talk to the patients and you're like, okay, I think you need to have a filler done or a fat transfer, or they're like, they're against that. What are you noticing what people are asking for? And how are you treating them? And when do you treat them?
Right. So that's such a great question. That's such a great question because we see these fat changes. The hollowness, and I just had a patient this week that didn't want to address the hollowness.
Right.
I'm like, trust me, your 40-year-old self is going to really appreciate this because it's but they want their face to look thin. So what really bringing them in is that change that they're seeing around the eyes that makes them look a little tired, right? The hollowness there, and then their skin, because they definitely don't want people to think that they're ill. When they're no longer getting those compliments anymore, they come in, right? So I do recommend initiating things that are going to stimulate collagen and elastin and preserve the integrity of their skin and keep their skin health optimized.
Yes.
I do that with lasers and devices. My favorite combination is an IPL with a clear and brilliant. That's like no downtime. And then I generally put them on XOMD, right? Because XOMD decreases inflammation, increases dermal moisture content, and that's what allows it to look more dewy and radiant. And then
also insulin-like growth factor 1 is, in theory, is going up when you increase oxytocin levels in the skin, which XOMD perhaps does. And if so, that's another mechanism in which it can improve the appearance of the skin by driving more insulin into the skin cells.
Right.
But if we're going to talk about this GLP-1s, there's a couple of things that people always ask me about, and I think we have to talk about it real quick, and that's hair loss and muscle loss, and what happens if you go off the GLPs. Those are the three of the biggest questions I get. So hair loss, tell me, do you see hair loss in the patients that come in? Because it's reported in some studies up to 7%, and some 3%, and some not at all. But what do you think?
So I think that with introduction of any drug, you can absolutely see what we call a telogen effluvium in dermatology, where you see a temporary loss of your hairs that are in the resting phase, which is telogen. And so I do see that patients might go into that, and you usually see that after 3 months from the insult. The insult is essentially defined as when the body perceives, the drug has hit them. So 3 months after the initiation of the drug is when I would see that. If I see it later, it's generally not because of a telogen effluvium. It's because from a nutritional status standpoint,
Right.
they are no longer optimized, right? So there are key building blocks that you need to be creating hair, especially iron. And so if you're not absorbing or you're not eating a certain amount of iron is going to go to your hemoglobin to carry your, oxygen all over your body before it goes to your hair so that you have nice hair. So you'll definitely see that you're not growing, you don't have the building block because you're not absorbing as well to grow that hair. So at that point, you definitely need to see a dermatologist so that they can at least work you up to determine what it is. And then you can get properly
So
optimized.
muscle mass, the same thing, like hair loss, is being reported in some of these studies. But I've done a deep dive into the literature, and yes, you lose muscle mass, but you lose muscle mass anytime you lose weight. And some of it is normal to lose muscle mass because you're not as heavy, you don't need as much muscle mass. Also, some of the muscle that's being regenerated is healthier muscles.
Right, so I want to pause that. So you're not as heavy, so you don't need as much muscle. So for those that are listening, you don't need as much muscle to carry you around and carry all that weight around. That's why you don't need that much muscle, okay?
Right. So it's controversial, so I'm not going to go one way or the other, but I'm telling you, I'm reading all the papers on this, and you do lose some fat mass. That's the majority of what you lose, but you lose something called fat-free mass. Fat-free mass are things like your organs and dermis and other tissues that's not fat and soft tissues. Of that fat-free mass, 50% is skeletal muscle mass, and you do lose that, but how much of that do you lose? Well, it varies based on the drugs, and the dual agonist ones, which are the tirzepatides, it's less than the semaglutide, which is the single agonist GLP-1s. So it's getting, as the drugs get better, it seems to be less muscle mass loss. But of the people who lose muscle mass, it seems to be correlated more with the nutritional deficiencies, just like you said with hair. So the key here is that if you maintain nutrition, if you eat well, how much? You have to eat more protein. 1.2 to 1.5 grams per kilogram per day. If you're staying there, then you should be increasing your nutritional load. You shouldn't have the muscle mass. You shouldn't have the hair loss as much. So I think what that behooves us to tell people is that if you're going to be on these drugs, you can't just get it from some compounded pharmacy and think that you can manage it yourself. You really have to be on top of these other things, like seeing a dermatologist for your hair, seeing a physiotherapist, or working out, or resistance training to make sure your muscles are staying strong.
Right.
And that's important too. And there's other things that happen when you're on this drug that may affect you metabolically, which means you really should be followed by a physician who's an expert in this.
Right, an integrative medicine doctor, right? Because then they might put
Or
you on
endocrinologist or someone.
peptides, like injection peptides to help you with your muscle building. Because remember, after the age of 40, your ability to create new muscle is not as easy as when you were in your 20s or 30s. And there's something called sarcopenia that starts to happen as you're in your 40s and beyond. So if you start these drugs and you are 40s or older, your ability to already create muscle mass is not as good as it used to be. And so you're already losing muscle mass. And so you definitely need to be on a good resistance training workout. Maybe the workouts that you were doing before are just not going to be the ones that you need now. Really working on the glutes, the glute maximus, gluteus minimus, something that people say is like the Ozempic butt, right? Like you lose that muscle group first, because that muscle group is your largest muscle group of your body. So it's like you need to just be with someone that recognizes this and is working out the proper muscle groups so that your whole body is not being negatively affected by the weight loss.
And then the other question that always comes up is well, what if I stop? I'm going to gain it all the way back, so I'm not going to do it.
Well, there's good literature now, right? If you stop, how much do you actually gain?
in the original trials, the semaglutide, people were gaining 2/3 of the weight back within a year. Now they stopped the medication, they went off it, and they followed them, and they gained 2/3 of the weight back. So that's pretty significant.
So in 1 year, you stop. At a year later, you have gained two-thirds
in the
back.
original trials. But in the
Okay.
dual agonists, so as the drugs keep getting better, the newer drugs, the tirzepatides, in that trial, now they were given a placebo. So after they finished the trial, half the group was given placebo, half the group was kept on it. The ones that were given placebo maintained 10% body weight. So originally lost 20% body weight. They maintained 10% body weight, which means they gained half of it back.
Half of it back.
So they're on placebo. Now here's
At
the
a
interesting
year?
thing. A year later, yeah.
Okay.
So they're taking placebo. And a small percentage, I think it was like 10% of patients or so maintained the weight loss. So there was 5%. It was a small percent of patients, but there were some people who maintained the weight loss completely.
Okay.
So there are some people that maintain the weight loss even after they stop, but they were on placebo. So the question is, how long can you be on the drug? Like, is it a lifelong drug? Once you're on it, you have to be. And we don't have that answer, but likely it's that you can lower the dose, and we're still trying to figure it. Well, we don't know. It hasn't been figured out yet, but I think we're moving towards that. So you don't necessarily gain all the weight back. It's not like you're automatically going to gain the weight back. Yes, you might gain the weight back, and likely if you go off it and you start eating again, you're going to gain the weight back. But it doesn't necessarily mean you're going to. So you could maybe be on it for a while and then go off it, or you could lower the dose.
Right. But I think that maybe what people are doing, this pulsing, like losing the weight, then taking it again, taking themselves off of it, gaining and losing may not necessarily be the best thing.
So you're saying do you do it cosmetically, like the person wants to lose 10 pounds.
Right.
What do you think about that? Would you tell someone, would you recommend to your patients, like, listen, you might
if they've really, maybe like after a baby, or if they're menopause. I have a lot of patients that are entering menopause. Metabolically, you start to see a shift. You no longer can lose weight like you used to. It's definitely a nice supplement, but I think that, once, to your point, if you're going to gain, if 50% of folks are going to gain it back at a year, then is it something that really needs to be more microdosed?
But those are obese patients.
Okay. So we don't know, right?
So your patient comes in and says, Dr. Fabi, I want to lose 10 pounds.
And they've tried everything.
Yeah.
I think that if they've tried diet and exercise, and they're, optimized, seeing an integrative medicine doctor hormonally, they're checked and they're good, then I would say it's not a bad idea as long as it's under the care of an integrative medicine.
So it's interesting, right?
physician.
So we're really on the cutting edge here right now, because
Right.
you and I are talking about something that it's not FDA approved for cosmetic weight loss.
Right.
Now, what the long-term effects, Dr. Fabi? Do you know the long-term effects of it? Now, the product's been around since 2005, so it's not like it's a new fly-by-night drug. It's been around, so we know some of the side effects. And if we know that sugar's inflammatory, and we know we're taking down sugar, and we know that it's got all these wonderful benefits, like it's protected for your kidneys, for your brain, for your heart, should we be considering it at a microdose level for people that are healthy and want to lose a little bit? Now, I'm not suggesting that. I want to make it very clear.
Right.
But that's got to be on everyone's mind.
I mean, it is on my mind mainly for the cognitive,
Right.
effect, right? I mean, this program is called Lipstick and Logic, mainly because of my brain. So we do have to protect it. And if there is something that is going to potentially protect this brain, I am going to do it. So the brain fog that, many of us get. So anyway, doctor's orders. So doctor's orders, what would you recommend to your patients that are thinking about, that are on this drug?
Okay, it's a great question. So I think at this point, what I would say to someone, if you cosmetically want to lose a few pounds, and I'm not going to recommend to take this drug right now because it's not FDA proven for that. Having said that, I am incredibly curious. My hunch is that yes, soon we'll have studies that this drug at a microdose will be an effective treatment for losing a little bit of weight. It'll also be effective treatment for cognitive and cardiovascular health. So I wouldn't be surprised in the next few years if we start to see those studies. They're not out yet. So I'm hesitant to give this to people right now and say just go on it cosmetically if you want to lose a few pounds, because I think there's other ways to do it. But to your point, if you have a physician who's very learned, who's very experienced with this, and they were to recommend it, I'd completely be in line with that. And I'd be like, okay. And I'd be honest with you, I think about it myself. It's like, if it's that much of a miracle drug, and it's hard to say that because in medicine, things always come and go, and we've been around a long time, and statins are the biggest thing, and everyone's on statins, and then next thing you know, it's like, well, we don't all need to be on statins. And so many drugs that I was prescribing when I was, a resident and a fellow are now like not even used anymore, or
Right.
taken off the market for various reasons. So things go in cycles, and I don't want to be the first one to jump on a big trend. But I mean, the data on this is just so overwhelmingly strong, and the side effect profile is low, and the therapeutic index, meaning the safety of it, is pretty darn good. So
I would say that if you're a cosmetic patient of mine and you're considering using it just to kind of shave off those 5 or 10 pounds after pregnancy or because of menopause and a decrease in just your baseline metabolic rate, I would say that be aware that it does have cosmetic implications if you're
Yeah.
solely doing it for that aesthetic benefit, which is that we do see a preferential volume loss along the temples and periocularly around the eyes that can absolutely make one look older. So I would be prepared to also potentially treat those areas if the intention is just
at the same time they started,
aesthetically. So I would, at the same time they start, I would definitely make sure that they're already doing things for their skin, so that, because ultimately your skin is your visual certificate of health. If it does not look healthy, it doesn't matter how much weight you've lost, you're not going to look as good as you could look. And so my disclosure and bias is that I'm a dermatologist, so obviously I look at that and my eye is a little more refined to see that change. So I would be definitely on a good laser and skincare regimen to take care of the skin preemptively before starting it. And I would also make sure that if you're 40 or over, you're seeing an integrative medicine doctor to perhaps help you with any hormonal shift that you may see for being on this drug. And then also somebody who can help guide you with working out so that you don't develop the Ozempic butt, which flattens out, and probably a good segment for the next time, which is, having completely a rail thin body, is it the most attractive thin? I don't know. I think that having a little bit of curves, is attractive. So you don't want a completely flat butt, because that's a visual cue of age, especially in a woman if you have no curve.
Okay, I want to summarize your doctor's orders. You're
Yes.
saying start early.
Right.
If you're going to go on one of the GLP-1s, start early with aesthetic treatments or aesthetic
Correct.
maintenance. See an integrative doctor, you're saying, as well, and see other like a
Dermatologist.
but also like a physiotherapist or nutritionist. So make sure you have all those bases covered if you're
Right,
gonna
if you're doing this for aesthetic reasons, because
Yeah.
you don't want the other things to collapse.
Yeah. All right, I think those are good orders.
All right, there you have it.
All right, that was a good session.
Lipstick and Logic, make sure to leave us comments in the section below about what you want to hear the next time.
And the juicier the better.
We'd love to see you.